Thank you very much. I come from Tianjin Hospital, China. My topic is selection of UBE, MAD, PLED in the treatment of lumbar disc herniation and stenosis. There's no conflict of interest. Spinal endoscopic surgery has been developed for many years, such as MAD, first used in 1997 by Foley, and mobile MAD by Desdondo with 3 canals, and PLD with water medium for many years. It was widely used now, and UBE has been developed for many years, especially in recent years in Korea, well developed. My experience, we have used MAD since 2003 for more than 5,000 cases, and PLD for more than 5,000 cases, and UBE for more than 200 patients, including fusion. Since lumbar disc herniation and stenosis is very common in our practice, so that's a controversy. Which technique is the best? So we evaluated the characters, result, and the best indication of MAD, PLD, and UBE. From 2015 to 2021, we have included 3,920 patients with lumbar disc herniation and stenosis. Intervention include MAD in 1,625, PLD in 2,095, and UBE in 200 patients. We evaluated the characters, pre-op disc herniation and stenosis according to CT, MR, and the result during follow-up of 3 to 60 months. The MMED, the tube can be tilted in variable directions, and the cone-shaped tube is well fitted to the lamina. It has 3 canals, 8 millimeter working canal, 4 millimeter for suction, and 4 millimeter for endoscope, and a groove for no retractor. It's mobile and self-balanced with air medium. The incision is about 2 centimeters. It can be moved and tilted at will. 3 canals don't interfere with each other. One hand operation, left for suction and right hand for instrumentation. With special locator, the disc is localized before operation. Intraoperative fluoroscopy is usually unnecessary. Extensive exploration can be performed to remove sequestered herniation, and is convenient for bilateral decompression while unilateral fenestration. The fusion can be done for instable cases with fine bone chisel, spacer ureter, and fusion tube. PELD, for PELD, precise targeted installation of tube is important, such as PTED, PID is routinely used, as well as cervical keyhole and thoracic disc herniation and decompression. With big tube, lumbar stenosis can be decompressed, including bilateral decompression with bore and kerrison. For UBE, it has 2 portals, one for observation with endoscope of 0 or 30-degree endoscope, one for operation with conventional bore and kerrison. With radio frequency, high-speed bore for conventional decompression. The character, it has biportal. The endoscope and the instrument are inverted triangle with continuous irrigation of water irrigation. The vision is clear. The instrument is not limited by canals, except for soft tissue. our incision is according to the pedicle projection and AP fluoroscopy. On left is upper edge of pedicle projection. Right is the low edge of pedicle projection. The lateral fluoroscopy is checked to check the disc space for convenient to decompress and discectomy. Half tube or spring leaf is to open the deep fissure. We make an initial cage cavity at the junction of low edge of lamina and spinal process for a strip muscle on the surface of low edge of lamina. The instrument is close to the end of the endoscope. We have some confusion in the early stage of UBE, including soft tissue occlusion. Sometime in the first cases, the instrument may be not found, perhaps due to the cross and separation of lens and instrument and soft tissue around the lens. So we propose subperiosteal strip and fluoroscope examination. And imagine the lens like a flashlight to look for the instrument. Sometime when you continue make the fissure open with a half tube. The soft tissue with Biportal may be a little more big than PLED. With high energy radiofrequency, it's efficient to remove high plastic ligament and preserve inner layer of ligament flavor for clear expose. With decompression with conventional bore and kerosene, the direction is the tilt and the free direction of instrument, one-hand operation. Precise remove of the medial part of articular process for sufficient decompression and preserve of the facet joint. It's very convenient for sufficient bilateral decompression through unilateral penetration. The basis of spinous process is removed with high-speed bore, and contralateral compress is decompressed. During fusion for some unstable cases, the installation of cage is visible with UBE. For 1,910 patients of lumbar disc herniation without stenosis, most of them, 1,820 received PLED, and including 1,010 patients received PTED, mostly at L1 to 5 level, and 810 patients received PID, mostly at L5S1 level, and 75 received MID, and 15 received UBE, usually for far-sequestered herniation or osteochondrosis. For 675 patients with herniation and stenosis, most 560 received MAD, 65 received UBE, and 50 patients received PELD. These patients with disc herniation and mild stenosis received PETD with decompression in 270 degree decompression with a good result. This patient with disc herniation and stenosis, the stenosis is very severe, so he received UBE with decompression and discectomy with a good result. For lumbar stenosis, 1,335 patients with mainly stenosis without obvious herniation. 990 received MAD and 225 received PID with big tube, and 120 received UBE. This patient with stenosis received UBE with bilateral decompression through one unilateral penetration with sufficient decompression. So the comparison of MAD, PLD, and UBE. The PLED has the smallest incision and one portal with the water medium. The radiofrequency endoscopy bore is slender and delicate and more easy to damage. For MAD, the incision is 2 centimeters with L medium, but the instrument is conventional instrument and biportal is durable and more cheap. For UBE, it has 2 portal with water medium, the high energy radiofrequency intracranial radiofrequency is consumer is more expensive in our hospital. For PLD, the target the tube should be installed precisely with more fluoroscopy, more irradiation. The decompression area is limited. Small than other two technique. The tilt of instrument is limited by the tube. For MAD, the decompression is more large, and the tube is the instrument is limited with tube for contralateral decompression. With UBE, it should make a cavity and with a wide decompression, and the instrument is not limited by the tube for contralateral decompression. The mean time of operation time is PTD 40 minutes, PID 38 minutes, MAD 35 minutes, UBE 45 minutes. The length of hospitalization, PLE 1.9, MAD 4.2, UBE 3.6, perhaps due to the drainage after operation. The rate of reoperation, PLED 2.1%, MAD 0.6%, UBE 0.5%. The result is good to excellent result. The percentage is to about 92%, no significant difference. So according to my experience, the lumbar disc herniation is the best indication of PELD, L1 to 5 level with PTD, L5 S1 level usually with PID. For lumbar stenosis, severe stenosis may be the best indication of UBE, MAD, and PID with big tube. For lumbar disc herniation and stenosis, the selection of technique may be depend on the situation of situation and the need of discectomy or decompression. Thanks for your attention.
Thank you, Dr. Shi, for the wonderful presentation. If there's any questions, please take note. You can put in the chat box, or you can ask at the later point. We will be going to the next speaker. I think, Dr. Song, are you ready?
Okay, I will start. Today's topic is the UV4 thoracic disease. First, let's discuss about anatomy, thoracic anatomy. First, thoracic spinous process slant back and downward. This make you confused, difficult to check the thoracic level under CM radiography. Okay, this one you can see, especially mid portions thoracic is difficult slanted spinal processor. Important thing is different level between body and tip of spinal processor. Also, missed like level disorientation. Second is thoracic lamina overlap each other from above downward. Also longer distance between disc level and interlaminar level. So it makes you to be unsuitable to do conventional interlaminar approach in endoscopy. So I will always perform through translaminar approach in UV. This one here, common OLF site here. I will approach directly through translaminar, very short distance, but interlaminar approach longer distance. This one also uneven posterior surface lamina. This is thinner and slightly depressed on upper half. This area is caudal attachment of superficial layer of above ligament flavum. Also slightly yellowish upper half and slightly pinkish lower half of lamina. The borderline of upper and lower half on posterior surface of lamina is the landmark to assuming the cranial attachment of ligament flavum on anterior surface of lamina. This one here. This one upper half, lower half borderline here. This directly anterior surface may be cranial attachment of this one also. On okay, this one here, yellowish is the upper half. This one pinkish, this borderline. This is important because this point is the starting point of drilling. Next, ligament flavum, grossly superficial layer or deep layer, but the caudal attachment of above superficial layer on posterior surface of lamina is the same level as the cranial attachment of deep layer on anterior surface. OLF is common at the cranial attachment deep layer of ligament flavum. Okay, this one upper low superficial deep. This is a relatively same level. This one. Okay. Also, the structure of the around isthmus transport process, articular facet, demi facet of head of rib is important. Also, this one. Okay, this direction is the endoscopic transforaminal approach. This one important. Next, more longer epidural vein and foramen area. This is the conventional approach type. You can see here, especially anterior ventral surface of sacral sac commonly through lateral extracavital approach in conventional surgery. This is the same approach, endoscopic transforaminal. Okay, this is OLF, thoracic soft hernia disc, hard disc is thoracic disease. First, in UVE is performed through translaminar approach for OLF. This keel laminotomy. This one here. This is the borderline direct drilling through translaminar. This area is the common site of OLF. This one preoperative MRI, CT, post-operative MRI, full decompression. This is the translaminar approach. Okay, I will show you. This is pink, yellowish, pinkish. This borderline. This is drilling starting point. Also, paper thin drilling. Also, this one lamina opening. But important thing is to find out the central pad. Central pad make a good orientation. Also, this area more safe and less adhesion. So, okay, first important thing, first checking point is the borderline next is central pec. So thoracic surgery is difficult, but if you find out central pec at first, your next step is more safe. But in this case, if there is no central pec, very difficult, hard surgery, I think. Okay, sequence, OLF, remove serial. Finally, you can see here, old, long-standing compression area, this type. Okay, this is OLF, this type, pre, post. Okay, this is the here, OLF central and extended foramen area. This is the preoperative, postoperative. This is the common figure of the OLF. Okay, this multi-level and signal multi-level OLF with myelopathy. One-time decompression this time. Okay, this is a very dangerous or serious case. This, okay, this patient had completed ossified dura. First, removal of this one ossified dura. But important thing is this area, this is the arachnoid membrane. Important thing is to preserve the arachnoid membrane. After that, then tacocom apply. Next, okay, please. Okay, this is preoperative and postoperative here. Arachnoid membrane and tacocom. There is no CSF fluid leakage. Okay. Next is soft herniated disc. This one transforaminal. Also, this is yes, severe T12, 11, 12 herniated disc myopathy. This approached transforaminal, but next is transpedicular approach. This one here, ruptured disc. This I will approach it through this type transpedicular approach. Okay, this patient had multiple surgery. So screw fixation here, T12L1, ruptured disc about the migration, very severe compression to sacral cord region. Okay, I will first target point is isthmus here. Isthmus, I will approach transpedicular here. This pedicle may be medial to caudal, drilling out. Next, here, paper thin drilling, and I will find ruptured disc. I removed through transpedicular area. Also, this preoperative, postoperative decompression. Okay, next is a hard disc. Maybe thoracic hard disc is a very challenging case. I will show you transforaminal approach. Okay, this is my transforaminal approach. Hard disc is a very, very challenging case. So this direction is similar to conventional lateral extracavital approach. Important thing is I will remove half of joint, lateral half removed, and also the angle. Angle is important, maybe 35 to 40 degree important. Okay. First thing is the important first step is to make working space. You can see here, the post-operative CT scan, you can see removed both edge of body. This video, you can see height is a disc space. Also, this both edge of body removed. I will show you. Second is push it down the calcific bone spur and calcific ligament ligament also remove this one. I will show you video here. This space, I will check here, dura and cord, also push it down. After push down is important. So after then, I will remove bone spur and calcific ossified the ligament, this one. Okay, this is the endoscopic thoracic decompression for hard disc. Okay, you can see here preoperative very severe bone spur here. CT, preoperative MRI and CT T89 severe bone spur, postoperative MRI CT totally removed this day. Next case, another case is the T1011 hard disk here, preoperative MRI. Okay, initial target point here, roughly here. This is a post-op MRI. Okay. Also, thoracic UV has a contraindication. First, severe OPLL tumor infection. So it is important to make surgical space enough for safe and good result in thoracic. So UVE is make clear magnetic field, skip handling, also lens inside. I commonly 0 degree, but in case of hard disk 0 and 30 degree combined, I used. Conclusion, UV thoracic posterior surface, first thing important is the anatomic review is important. Second, you must learn type of approach also. Please try to do thoracic code UV, code level UV after many cases of lumbar UV. Thank you, everyone. Thank you.
Thank you, Dr. Song. It's always wonderful to hear your talk with very deep insight in a very more uncommon endoscopic decompression, probably common in your practice, but thoracic OLF disc uncommon condition, and you have demonstrated very well how to perform this highly technical surgery. Thank you, Dr. Song. Next, we have Dr. Toi Noi Nguyen from Ho Chi Minh University Medical Center, Vietnam. Dr. Nguyen is a member of Vietnamese Orthopedic Association, Ho Chi Minh City Orthopedic Association, and his topic is UBE decompression for osteoporotic vertebral fracture, how I do it. Welcome.
Dear colleagues, I'm Dr. Nguyen Ngọc Thoi. I'm from University Medical Center in Vietnam. And I'm very happy to be here today and present my topic about UBE decompression and vertebroplasty for osteoporosis, vertebral fracture. The incidence of osteoporosis vertebral fracture has increasing by the aging population, and most of the disease can be managed successfully by conservation. And a few of them is failed. So there are many reasons make the patient have the failure result. And among of them is overlap with neurological diseases. And the reason of neurological diseases may be the kyphotic deformity, or the intravertebral instability, or the bone fragment that impinge neural elements. And there are many ways to control the disease, and most of them is surgery. And the surgical approach should be kyphotic deformity correction and maintain the stability, and neural decompression and early mobilization. But in some case, the elderly patient, they have severe osteoporosis, or they have mobility, and the surgical may be inappropriate because it can make the risk of screw pull out, hardware failure, sometimes infection, or maybe mobility, mortality rate case. So we can take a look in medicine literature. The traditional open surgery treatment this kind of disease is posterior spinal shortening or maybe modified pedicle subtraction osteotomy. But as I said, some elderly patients, they have severe osteoporosis or they have mobility. So the surgical approach may be inappropriate. And then many surgeons try to find out another salvage therapy like endoscopic decompression and vertebroplasty in this kind of disease. And Dr. Salim Center, he did this disease by endoscopy, but just uniportal. How about biportal? In 2021, Dr. Min Sok Khan in Korea, he conducted research that is biportal endoscopic posterior lumbar decompression and vertebroplasty for extreme elderly patients. And he made a conclusion that this kind of surgery is a type of salvage therapy that reduces the surgical mobility, require major spine surgery under general anesthesia, and provide good clinical outcome. So I agree with him. In my experience, I did some case like that. And today I want to share my experience with my college. So that's a 72 years old female patient, and she presented to our clinic with severe pain at right hip, thigh, and low back pain for 2 months. And on examination, we find out that she had right hip flexion muscle strain, grade 3, and difficulty while walking and sitting. She has osteoporosis, Cushing syndrome, hypertension, and diabetes mellitus. So after consultation with her family, we conduct a UV decompression and vertebroplasty for this case. This is the X-ray and MRI CT scan of the patient. You can see she has severe osteoporosis, and she got complete burst L2 fracture, and there are some bone fragment impinge the canal and the right L2 root at the subarticular space. So the first step, this is the operating room setting. Very familiar with us. And stage 2, I did vertebroplasty. In this case, I use a unipedicular approach because the patient has severe osteoporosis and 2 months collapse, and she had mobility. So I just use one approach. And after the procedure, you can see that the BMMA spread reach to the end plate of the upper and the lower end plate. And due to Dr. Yu Ho, he said that in case the BMMA distribution reach to the end plate or contact to the both end plates, this can reduce the reoperation rates, and it can maintain the stability of the spine for a long time. So in this case, I did not add the shock segment of shock segment fixation for this patient. If the BMMA did not spread to the bone and plate, I recommend that we should add a shock segment percutaneous spine fixation. Okay. And stage 3, we do UVE decompression. First of all, we make incision planning. I make a working portal and endoscopic portal 2 centimeters lateral to the pedicle of L2 and L3 with the target point at the part interarticularis or isthmus. That is the lateral of the part. You can see the green color is the skin incision of vertebroplasty, and the yellow color is the working portal, and the right color arrow is the endoscopic portal. And after we go make a cavity and go inside the cavity, we first, first of all, we do partial resection of the right L2 transfer process. The A is the partial transfer process before I did resection, and B after resection. And then we identify the L2-3 foramina. We try to move down by the burr or Carrison, and then after this stage, we can find out the nerve root, a part of pedicle and some part of the transfer process, or the part after resection. And at this stage, we do pediculectomy to remove the fragment after we go inside the canal. You can see the bone fragment inside the canal at the C and D. Okay, I will show you the video. This is the space we make after we make the working portal and endoscopic portal, and then I resection the partial transfer process, and I move down. And I feel the pedicle and the foraminal. And resection some part of ligamentum flavum to expose the nerve root. I think this area we should we must do the hemostasis meticulously. Okay, you can feel the foramina and the pedicle. And now I did the pediculotomy to go inside the canal and have it spawn. And hemostasis meticulously. Okay, now we go inside the canal and the nerve root is exposed fully. Okay, you can see this is the bone fragment inside the canal. Okay. And find out more bone fragment. Because the patient has 2 months collapse, so many bone adhesion to the nerve root. So very difficult when we remove the bone. Okay, and the final, we can check the final of the decompression under C-arm, and whenever you find out the full lead of the nerve root tracts and C-arm, you can make surely that your decompression fall. Okay, and the result, the patient mobilized with the lumbosacral causes. In the next day, remove the drain on POD1, discharge on POD3. The VAS improved from 9 to 3, and the patient can walk without assistance 1 week later. And 3 months later, the VAS just 1. And this picture is the skin incision. Okay, and the result, we can see that the bone fragment in a subarticular space at the right, it disappears with the right, the red arrow, and there are no just a small of the pedicle recession. And I think vertebroplasty and UV decompression is a safe and effective technique. And the successful formula is personalized medicine. And I think UV can do the thing that open do. Thanks.